get sleep right now. So, you see, we are going to talk about surfactant administration and CPAP at the same time. And the question is why to put these topics. It's okay? What to put two big topics in the same lecture. And I think we have been witnesses of a big change in the way how we are treating small preterm infants. And you know, if you look at the studies, for example, in the last 20 years, trying to reduce the incidence of PPD by changing the methods of ventilation. You read everything what was done in the NICU, but never wrote on the paper what happened in the delivery room. And there was always a big separation between the delivery room treatment and the treatment in the NICU. And I think that this difference will disappear in the future. In many hospitals, and that's the case of my hospital in Austria, the delivery room is one room of the NICU. So there's no difference anymore between delivery room treatment and NICU treatment. And I want to convince you that these two important therapies in neonatology belong together and shouldn't be separated from each other. So this graph shows you the amount in percentage of babies are treated with intubation and ventilation, not with CPAP, but with ventilation. And you can see that, of course, babies with 23 weeks of gestation or less, practically all of them have to be intubated. But this is a huge decrease in the incidence of ventilation only in a few weeks later. You see with 26 or 27, 26, 25 weeks, approximately 40 or 30% of the babies have to be intubated. Of course, the data are completely different if you see different hospitals or countries. But what this slide shows you is there has been a decrease in the use of mechanical ventilation in small preterm infants. And this is only possible because of the use of another therapy, which is an alternative therapy, and that's the CPAP therapy. And you see these are data from Australia, from Colin Morley, showing the different gestational ages of preterm infants and term infants as well in different years, and the amount of babies treated only with CPAP. No ventilation, just CPAP therapy. And you see on the last years there have been a huge increase in the use of nasal CPAP, mainly in preterm infants between 28 and 34 weeks. So this is the main bulk of patients being treated with CPAP. But interestingly enough, also babies at term, 39 to 42 weeks, also have an increase in the therapy of CPAP. So you see this is a very common therapy nowadays, not only for preterm infants, but also for term infants. And to understand why CPAP is so effective, especially for the preterm infant, it's important to understand the differences between the physiology of a small preterm infant and term infant. And you see probably the most important thing is that the small preterm infant has a decreased compliance, a lung compliance. And this is mainly due to a lack of surfactant, or surfactant has not the quality of the surfactant of a term infant. But this is not the only reason. The other reason is that the babies have more water content in the lungs. And probably the term respiratory distress syndrome and the term transient tachypnea, this is probably the same disease in two extremes of the spectrum. So all babies with respiratory distress syndrome have lots of water in the lung at the same time. And many babies with transient tachypnea have less surfactant than normal, or the quality of surfactant is not as well as in babies which are healthy. So anytime you get more water in the lung, let's say an example would be the patent ductus arteriosus, you have a lung edema, the compliance of the lung will decrease. So this is the second important cause for decreased lung compliance in the preterm infant. The other problem is that the inspiration is very ineffective. That means that the baby makes an effort, but the baby doesn't get enough air. So the tidal volume is less than normal because this inspiration is not effective. And the main reason for that is the instability of the thorax. If you want to say in physiologic term, the high compliance of the thorax is a problem for the baby. Yeah. The horizontal orientation of ribs and the small area of apposition of the diaphragm contribute as well to this problem. And the other problem is that the baby has a difficulty to maintain the lung volume. And you know, it's very interesting to see the smaller the baby you observe, the higher the respiratory rate, even in the presence of a normal CO2. And the question is, why these babies breathe so fast? And one reason for that is that the baby creates an auto beep. It retains air in the lung by shortening the expiratory time. Because the maintenance of volume in the lung is not effective in the small preterm infant, precisely because of these ineffective or the high compliance of the thorax. So the baby tries to maintain the lung volume by breathing very fast and shortening the expiratory time. What you usually should avoid when you are ventilating a patient. You don't want to create an auto beep or air retention. The lung volume is less than a normal baby. We already talked about that. And there's less tonus in the laryngeal muscles to retain the air in the lungs. So the baby can, and you see that every day in the clinical practice, if a baby makes a prolonged apnea, and you know apnea is always in the expiration, you can see a very, very fast decrease in the saturation. You can test yourself. You put your saturation on your finger, you exhale and retain the exhalation for a long time, and it's very difficult to get a fall in the saturation. You will have to breathe because of an increase in the CO2, but it's almost impossible to have a desaturation fast. And you see small preterm infants, they have desaturations with short periods of apnea of 7 seconds, especially babies with BPD. And the reason for that is the small lung volume they have. And they lose the volume very easily. This slide shows you what happens when your thorax has a high compliance. It's very flexible. And you see, in a normal state, you don't move your lungs. You don't have muscles in your lungs. What you move is the size of the thorax, especially the diaphragm if you're a baby. When you move the diaphragm downwards, you get some volume in the thorax. This increase in the volume causes a negative pressure. And this negative pressure is going to be compensated by the entrance of air into the alveoli. So that means that this volume you get, this is the tidal volume, should be the same volume you gain by expanding your thorax. Is that correct? If your thorax is not stable enough, and you want to get the same tidal volume, by moving the diaphragm and causing this negative pressure, the negative pressure will deform your thorax, losing volume again in this space. So the baby has to make much more effort to get the same tidal volume, which is in many cases not possible. So the baby falls in a respiratory insufficiency. That means that the baby is not able to get the normal tidal volume it should get by making the same effort. Okay. The other thing that happens is that the negative pressure sometimes also makes a collapse of the extrathoracic airway. A typical example of that is the so-called laryngomalacia or tracheomalacia, which increases, of course, the resistance to the air. And the more resistance you have, the less tidal volume for the same effort you will get. Okay? And this is the so-called area of apposition. That means the amount of distance the diaphragm is going to move. And of course, this distance is related to the amount of volume you will gain. And you will compensate by the entrance of air. And in the case of an infant, this area of apposition is much less. That means that the work of the diaphragm is not as effective as in the adult or in an older baby or patient. So what is the function of nasal CPAP in such a circumstance? And so the principle of the function of CPAP is very easy. you have a source of flow on one side. You have the respiratory, the inspiratory part of the respiratory system, the expiratory limb of the system. And this would be the alveolus or the lung of the patient. And if you don't have any resistance for the airflow, the pressure inside the tube will be probably very, very little higher than the pressure, the atmospheric pressure. So you don't have much pressure here. It's very difficult to measure that. But if you increase the resistance on the outlet of the system, you will produce some pressure in the system because of the resistance. And this pressure will distend, of course, the lung or the alveoli. This is the very simple mechanism of action of CPAP. The resistance could be water, in the case of bubble CPAP. Maybe many of you are using the bubble CPAP. Or can be the outlet ventile of a ventilator, which also causes an increase in the pressure by increasing the resistance in the outlet. So what are the effects of CPAP in this case? You are mainly applying a constant pressure, first of all, to the respiratory tree, and secondly, to the alveolus. And this explains all the actions of CPAP, the pressure applied to the airway and the pressure applied to the alveolus. If you distend the airways, you will decrease the resistance. If you decrease the resistance, you have more tidal volume. It's more easier to get air into the lung. You will decrease the work of breathing. And of course, these are two also effects of CPAP besides the mechanics of the lung mechanics, the avoidance of obstructive apnea, mainly obstructive apnea, and the improvement of laryngotracheomalacia in the case you have a certain collapse of the airway during inspiration. And with that, you're going to improve the ventilation, and you expect a fall in the CO2 if the baby has a respiratory problem. And on the other hand, you have a distension of the alveoli. You increase the alveolar diameter of alveoli which are open, already open. And maybe you can recruit alveoli or avoid that alveolus are going to collapse. And with that, you're going to increase the oxygenation. And it's important to remember that there are several things that determine how many molecules of oxygen will diffuse through a membrane. Of course, the most important of that is the so-called pressure gradient, the difference of pressure you have on one side of this tube and on the other side. This is represented by the lower concentration of molecules on one side. This is probably the most important determinant for the diffusion, but this is not the only one. And the second most important thing is the size of the surface diffusion. You see, in this example, I try to put exactly the same concentration of both sides. So let's say that the pressure difference in both tubes is the same. So the force trying to move the molecules is the same on both examples. But in a certain time unit, you have here 1, 2, 3, 4, 5 molecules diffusing through the membrane. And in this case, you have only 3, just because of the size of the membrane. And what is the size of the membrane in terms of physiology? It's the total amount of alveoli which are open. Okay? So if you distend an alveolus, the alveolus has more surface, the surface of diffusion will increase. And of course, if you open some alveoli which were closed, you're going to increase the total surface of diffusion. And with that, you improve the oxygenation. So this is the main mechanism of improving oxygenation when you apply CPAP or pressure to the airway. It's exactly the same mechanism of high-frequency ventilation. If you give more pressure, you increase the oxygenation just by increasing the total surface of diffusion. So resuming the effects of CPAP, you have here recruitment and stabilization of alveoli. You increase the diameter of the alveoli. If you increase the diameter of the alveoli, you increase the compliance at the same time. You probably remember Laplace's law. Anytime you distend an alveolus, it's more easier to distend it. It means that the compliance would be better. If you increase the compliance, for the same effort, the baby will get more tidal volume. If you get more tidal volume, you will eliminate more effectively CO2. The distension of alveolus will increase the activity of surfactant, increasing the compliance at the same time. If the compliance is better, you have less respiratory work. And if you increase the total alveolar surface by the distending alveoli, you increase the oxygen diffusion and you increase the oxygenation. So it's a lie to say that CPAP increases oxygenation but does not help to eliminate CO2. Because many people say if you give a baby CPAP, you have the risk to increase the CO2. It depends on the status of the lung, but in general terms, if you increase the compliance, you increase the alveolar diameter, you will eliminate more easier the CO2. And the question is, can CPAP really produce a hypercapnia? Well, before that, this is another example. Let's say this baby is being on CPAP with 3 centimeters of water, which would be, of course, a very low level of CPAP for a baby with a respiratory problem. And because of the bad compliance of this small alveolus, maybe this is a hypothetical example, of course, the baby will have to create a negative pressure of minus 25 centimeters of water to get a normal tidal volume. If you put this baby on an adequate level of CPAP, let's say 6 centimeters of water, you distend the alveolus, you increase the compliance, and because the compliance of this alveolus is much better than before, the baby will have to create only minus 20 centimeters of water to get the same tidal volume. So it sounds sometimes like a paradoxal, but if you increase the size of the alveolus, the compliance will be better. And maybe if you are ventilating the baby, it's exactly the same. Sometimes you increase the PEEP level, and after a certain period of time, you can decrease the peak inspiratory pressure. And this is sometimes strange because you usually say, okay, if I distend the alveolus in the expiration, my tidal volume will be reduced. But it depends on the compliance of the lung, of course, before and after you make a change. And this is the other thing. Many people are afraid of hypercapnia on CPAP. And the question is, if you make something wrong, for example, you are distending these alveolus too much to a very high level of PEEP or CPAP. In this case, of course, by distending the alveolus to the same level, the baby will get less tidal volume. But this is a pathological state caused by something which was wrong. If the CPAP is indicated, you are improving the size of the alveoli, you are improving the compliance, you are improving tidal volume, ventilation, and oxygenation. And what we have learned also in the last years is not to be afraid of pressure. Many people say the PEEP level is related to the pneumothorax, which is not always that true. And we now know that a PEEP, a high level of PEEP in the presence of respiratory disease is even protective in the case you are using very high levels of peak inspiratory pressure. There's a huge animal evidence, experimental evidence about that. So this is something I will not treat in detail now, but this is a resume of what we now know about CPAP. What is the evidence that CPAP is so good for preterm infants? As I told you, the animal or experimental evidence is huge. We know that CPAP produces less lung injury, especially in comparison to mechanical ventilation. Observational studies have showed, even since Marielle and Avery in the 80s, showed this difference in the Columbia University. You know, the incidence of BPD was very low in New York, and she could show that this hospital was using much more CPAP than mechanical ventilation. So the observational studies, there are lots of them, showing always less VPD, association between less VPD and more use of CPAP. The problem is that we were waiting for a big randomized control trial to prove that, and it came from Colin Morley at the last, and they showed less reintubation after mechanical ventilation, less mechanical ventilation, those babies treated with CPAP, but no difference with regard to BPD, and, very concerning, an increase in the incidence of pneumothorax. And there is a discrepancy between the results of these randomized control trials and what we got from observational studies or experimental evidence. This is the study from Colin Morley from 2008. It was a big randomized control trial. They tried to investigate the effect of early CPAP on BPD in comparison to mechanical ventilation. You know, 600 patients approximately between 25 and 28 weeks of gestation. And all these babies had a respiratory distress syndrome. This is important, you will see in the course of this lecture. If you change something in the methodology of your study, you get completely different results. So these babies all had the respiratory distress syndrome and were randomized to CPAP, early CPAP, or intubation after 5 minutes. You see they had a very high rate of prenatal steroids, which is very, very good. And these are the results at 28 days of age, showing mainly a decrease in the dependency of oxygen. The mortality was not different because this is a combined outcome parameter, death or oxygen treatment. So they show only with 28 days of age a difference in the treatment of oxygen, but with 36 weeks there were no difference between the groups. And as I said, very concerning, an increase in the incidence of pneumothorax to 9% in comparison to only 3%. And I want you to remember these numbers, because we will see all these percentages in the next studies afterwards. So you see, if you use CPAP in a baby with a respiratory distress syndrome, only CPAP, 1 out of 10 will get a pneumothorax after the date of this study. If you treat the baby with intubation and surfactant, you will get approximately 3% incidence of pneumothorax. They didn't show any significant difference in the outcome of these patients, but still then, I would be very concerned if a baby gets a pneumothorax in the middle of the night when only maybe a resident is on charge. So I wouldn't like to have this complication, even if you tell me that the neurological outcome was the same. So these were the conclusions. Early CPAP reduces the need for oxygen in 28 days, increases the incidence of pneumothorax, and doesn't alter the outcome at 36 weeks of comparison. So very poor result for those who were very fond of CPAP. To understand what happened in this study, it's important to understand what we have learned about surfactant in the last years. And that's the reason why these two topics belong together from my point of view. You know that there are several effects of surfactant. There's an immediate effect. This is the effect you see immediately after applying the surfactant. You see always an increase in the saturation. And this effect depends mainly on the distribution of surfactant in the lung. You know, it has been calculated that there are 250,000 binary branch points, division points in the respiratory tree. And the surfactant must effectively go through all of these differences of this separation of the respiratory tree to reach all the alveoli. So this effect depends mainly on the distribution. And we have learned what to do in order to improve the distribution of surfactant in the lung. But this is not the only one. There's a secondary effect which takes place usually after hours. You see, when you give surfactant, the baby improves immediately, but continues improving for several hours. Part of these effects is that the baby is losing water from the lung. And the other part is a very interesting thing is that this surfactant is being optimized in its composition. That means that the body takes the exogenous surfactant and combines it with intrinsic proteins, improving the quality of the surfactant. And the third effect is related to the style of ventilation or the respiratory status of the baby. And this is very, very interesting. This is just an example from an experiment in rabbits being ventilated with no PEEP or with a very low level of PEEP. You know, 3 of PEEP is probably very low for a baby with, even for an animal with respiratory distress syndrome. And you see here the compliance, so the improvement in the compliance. This is a control group. And you see 2 different surfactant preparations. And these animals ventilated with no PEEP in the expiration present a very moderate improvement in the compliance. If you ventilate these animals with 3 of PEEP, it's a very small change in only one parameter of ventilation. You cost double, almost double, the increase in compliance. So you see the effect on CPAP, of surfactant in this case is dramatically different just by changing one parameter of ventilation. And this is also very interesting. In this case, lambs ventilated for 1 hour, so 1 hour of ventilation, and then they get surfactant. And what we see is something we sometimes see in the clinical practice. You see the triangles is the oxygenation. Don't get confused of the graph. This is the oxygenation very low, the PaO2. You give surfactant, and it improves up to here. But after 4 hours, the oxygenation decreases again. So the baby, or in this case the animal, reaches after 4 hours almost the same status as at the beginning. And the question is, what happens here? You usually give another dose of surfactant in this case. Okay. And these animals were ventilated for 1 hour before the treatment took place. And this is a very, very interesting data from also an animal study. This is the amount of surfactant you need in the alveolar surface, not in the whole cells packaged in the cell itself. It's just the surfactant on the surface, the surfactant which is active on the surface of the lung. And this is the amount measured in this case as phosphatidylcholine. And this is the CO2 as a parameter which gives you information about the respiratory insufficiency of the animal. That means if you reduce the amount of surfactant in the lung, you expect that the CO2 is going to increase. So these animals here are in respiratory failure. Okay? And you see that you can reduce the amount of surfactant for a certain period of time, and you do not get any respiratory failure up to here. Approximately 2, in this case, millimole per kilo, phosphatidylcholine is necessary to have in the alveolus in order to avoid respiratory failure. And if you try to guess how much milligrams of surfactant is this equivalent to? 2 millimoles. What would you think? How much surfactant do you apply to a baby? How many milligrams per kilo? 100 to 200, okay?
Yeah, okay.
It depends on the preparation. Okay, but 100 is probably the lowest dosage. So 2 millimoles per kilo are equivalent to 5 milligrams per kilo. 5 milligrams per kilo. And if you remember the slide before this one, in those animals needing surfactant after 4 hours because the effect was going down, the compliance was decreasing again. The question, how is it possible that you give 100 milligrams, you need only 5 milligrams, you give 100 to 200, and after 4 hours you need another dose? What is the explanation for that? It sounds ridiculous. And the only explanation is that there is an activation of surfactant. You give lots of surfactant, but this substance is being inactivated in the alveoli. We now know that edema, alveolar edema, is very effective in inactivating surfactant, especially by the presence of proteins like albumin, fibrinogen, even lipids. And some babies are not responder. You give surfactant and they do not respond. They usually have something else. But this is a very, very seldom situation. What we usually see is the inactivation because of the presence of edema. And what is the cause for edema, for lung damage? You know, edema is always present when you have a lung damage. And one can be, of course, mechanical ventilation. You see in one example, animals were ventilated for 1 hour. This produces inflammation. But also spontaneous respiration. If you have a very low lung volume because of a respiratory distress syndrome, and I let you to breathe spontaneously, you are going to damage your lung through your spontaneous respiration. This is probably caused by atelectrauma. It's just speculation. We actually don't know. But this is a very clear thing. This is another example now in preterm rabbits. This is the response to surfactant after birth or after 30 minutes of ventilation. This is the only difference. One group of animals received the surfactant initially after birth, and the other group were ventilated for 30 minutes. It's not a long period of time, 30 minutes. And you see, if you increase the dose of surfactant, the amount of surfactant you give, you expect more response. But the response is completely different in those animals not ventilated initially and those animals being ventilated for 30 minutes. So you see the effect is half of the effect if you give surfactant initially after birth. So the main message of this is that you should apply surfactant as soon as possible. Because as long as the baby is breathing spontaneously with a low lung volume or the long mechanical ventilation you apply before you apply surfactant will damage the lung and will produce a diminishment in the effect of surfactant. You know, when I think back to my time as a resident, I'm talking about maybe 15 or 20 years ago, when I started making neonatology, the first time we came to the idea to give surfactant in the delivery room, we transported the baby to the NICU, and my chief asked, "What do you do with the patient?" And I said, "We gave surfactant." I was almost dismissed from the hospital. You know that? He said, this is not correct. You have to have the diagnosis. You need the X-ray picture. You have to have the baby intubated in the NICU. So it was a terrible day for me. And this is now probably what we should do. On the old days, of course, we didn't know that. But you see how there is a transportation of treatment of the baby from the NICU to the delivery room. With probably in the future shouldn't be a difference between both. So mechanical ventilation or spontaneous respiration with a low lung volume causes injury, probably due to atelectasis. In the case of mechanical ventilation, also volutrauma and everything what you already know. This produces formation of edema, inactivation and surfactant, and the formation of further atelectasis with more lung damage. So what will be the optimizing the therapy? If you take into account what we have revised now. You should stabilize alveoli to avoid atelectrauma, alveoli which are being collapsed and be distended again. You do it with a CPAP, of course, after birth. You don't want to wait for 30 minutes. You have already seen that 30 minutes is a long time of period of time. Secondly, you have to give surfactant as soon as possible. And third, you should avoid mechanical ventilation. And if you take these 3 points together, we come to the so-called INSURE therapy, which is probably well known, but I have seen many people from Scandinavia here, or from Denmark. Probably you know very well this treatment, but not every of you. Probably you know INSURE means intubation, surfactant, and extubation. So you intubate the baby just for the administration of surfactant, and then you extubate the baby again, put the baby on CPAP. We usually do that with analgesia and sedation. This is one of the most important conflict points between Americans and Europeans. Many people do INSURE without any sedation. We do. And it's very interesting that for more than 20 years, CPAP has been the main therapeutic option in many countries, especially in the north of Europe, in Scandinavia. It was first described by Pictorin in 1990, and the first randomized control trial was made in 1994 by Werder, and they showed mainly a reduction in ventilation. This was the main outcome parameter they found. And this is a relatively big preterm infant. I just want to show you, I think the baby was 33 weeks, but had a severe respiratory distress syndrome. They are giving surfactant now. The baby is intubated on opioids. So receive a little bit midazolam and fentanyl. We're giving ventilation with a T-piece, so peri-vent. We wait until the surfactant is inside, in the lung. You see the baby is having a little bit spontaneous respiration, so it's not very deeply sedated. And now the nurse is applying naloxone to revert the effect of fentanyl. We wait until the baby has enough effort, respiratory effort, and then we put the tube out from the baby.
So that means you have to have lines on the baby.
We put a line immediately after birth, yes. A peripheral vein, not a catheter. So you see the baby is now breathing very well. We put the tube out and then put the baby again on CPAP with the TPs.
And they do all nasal intubation.
Yes.
Which we don't.
So we are now probably not very orthodox method of stimulation, but some babies make some apnea. Okay. So there are several randomized control trials comparing INSURE therapy with conventional therapy. This is an Italian study from 2004. So compare mechanical ventilation with CPAP after surfactant, so INSURE. A small study, 27 infants, and the outcome need of mechanical ventilation. And they found mainly the same mechanical ventilation at 7 days, no patient in the INSURE group, 6 patients, approximately half of them. Oxygen therapy in days, 7 days versus 11 days. Mechanical ventilation in duration, 2 days versus 5 days. Second dose of surfactant, no one, 7. You see, second dose of surfactant means always inactivation. You have learned that. So more inactivation if you use mechanical ventilation. So very discrete results from that. In some comparison, and this is interesting, I would tell you why. It's a comparison of one study from INSURE with other studies evaluating CuraSurf and ExoSurf with mechanical ventilation, of course. Just the parameters. And you see the pneumothorax, this is why I want to show you. The pneumothorax, only 4% versus 15 or 70%. So this already data showing that using INSURE reduces the amount of patients having a pneumothorax. And you remember the data from the Colling-Morley study showing 9% of pneumothorax in those babies treated only with CPAP in comparison to 3% in those babies treated with mechanical ventilation and surfactant. So there's a review from Cochrane. 2007 was the last revision comparing INSURE with late surfactant and mechanical ventilation. 6 randomized control trials were included, and they showed less mechanical ventilation in the CPAP group, in the INSURE group, less air leak, this is also very interesting, again, and less PPD. Half of the patients having PPD. So if you use, and you know how difficult it is that the Cochrane library finds something. In 90% of the cases, you read there is not enough evidence to make any recommendations. Yeah? Okay. Another thing which is very interesting is that depending on the threshold, you put a baby on CPAP. If you put a baby on CPAP, and you have to decide when to give surfactant. The majority of people, maybe you are going to confirm that, take the oxygen dependency as the main parameter. Some people say we will accept 50% or 60%. Other people accept only 30%. But the lower the threshold you take, you will have, for example, less than 45%. You will have less air leak again and less PPD. And very interesting, if you take a high level of oxygen, so you accept the baby to have lots of oxygen, you accept the baby on CPAP, although the baby is very sick, in other words, you will have, of course, more of these complications and more even patent ductus arteriosus. This is difficult to explain. We don't know why, but it is something which was found in this study. And this is my favorite study from Mario Rojas, not because he's my friend, but I think this is one of the most elegantly designed studies for INSURE. It was a randomized control trial, comparing Ensure versus CPAP in patients, just CPAP or Ensure. And those babies were sick. They had respiratory distress syndrome. And this is important to take into account, as you will see in the next slides. So almost 300 patients, 27 to 31 weeks of gestation. Early intubation, surfactant, then CPAP or nasal CPAP alone. These are the outcomes, the outcome parameters. And you see they showed a reduction in the use of mechanical ventilation. And again, air leak, 2% versus 9%. So again, a reduction. If you compare this study with the study of Morley, the same amount of babies having pneumothorax only on CPAP and the reduction to 2% incidence of pneumothorax by giving surfactant. Later surfactant, also difference. And the BPD, again, there was an important difference, but the significance, the statistical significance was on the borderline for this outcome parameter. So you see, if I ask you, what happened with the babies on CPAP in the study of Colin Morley? Why do they have more pneumothorax? What was failing? Surfactant was failing. So surfactant, CPAP without surfactant is not an adequate therapy. Both things are important if you understand the pathophysiology of this disease. Just to remember, pneumothorax, 9% in the CPAP, 3% in those babies treated with conventional ventilation and surfactant. This is the other study. You already heard about that. It was a huge study with two main questions. One question was the saturation limits. The other question was this. And they compared CPAP versus mechanical ventilation and surfactant. But these babies were healthy or with respiratory distress. And all babies between 24 and 27 weeks were included. So these are not only babies with respiratory distress syndrome, all babies. And this is important, as I told you, if you change something in the methodology, you find completely different results. And the intubation was decided when the baby needed more than 50% oxygen. You already saw in the Cochrane review that if you keep it lower, you will have less complications. Okay? They didn't find differences in mortality. Babies with ventilation at 7 days was different. More babies without ventilation in the CPAP group. This was also ventilation, less ventilation in the CPAP group. So exactly the same. Only corticoids for BPD was also different. And what's really interesting is that the incidence of pneumothorax was the same, 7% in both groups. But if you analyze this more carefully, you see that in the CPAP group, you have more incidence than in the study from Mario Rojas, for example, of 3%. And the question is, what's the explanation for that? What these babies have more? And probably one explanation is that they waited too long until the babies reached 50% oxygen. So these babies were probably, many of them, were sick and needed surfactant, but they didn't receive surfactant. So that would increase the incidence of pneumothorax. And on the other hand, you have the patients of mechanical ventilation, and they had, you expect here probably 3%, as in the other study, because you are treating these. But you are treating also babies that were probably not sick. You're treating all babies with respiratory distress syndrome and without it. And this is probably a clue that to intubate and to give surfactant is a good therapy for babies with respiratory distress syndrome, but probably not very good for healthy babies. Okay? This is another study, the CPAP study, European study, 208 patients, 25 to 28. Prophylactic surfactant and fast extubation, so Ensure or CPAP. Also babies with and without respiratory distress syndrome. But they changed here the decision to intubate to an oxygen dependency of 0.4. So 40% oxygen was the indication to intubate these babies on CPAP and give surfactant. No differences in this parameters. A pneumothorax, you see, in the case of CPAP, very low. Very low. Probably because you are treating the babies on time, if they are sick. And probably because many of these babies were healthy. They didn't need any surfactant or treatment. And if you put them on CPAP, depending on the level of CPAP you use, but if you put the babies on 5 centimeters of water, maybe you are not doing something completely wrong, because all babies have a low compliance in the lungs, even healthy ones. Yeah. And the pneumothorax, approximately 7%. Again, you're treating babies with and without respiratory distress syndrome. And some people have started, especially in Germany, you probably have heard about that studies. The first randomized controlled trial was published, I think, last year. Giving surfactant without any kind of ventilation, they say. So they put a gastric tube into the trachea, and they apply the surfactant very slowly, because if you put in as a bolus, the baby will get in apnea, so you have to ventilate. And this is, we have tried this method several times, even in Vienna. If I understand correct, the people from Vienna here? No, I think from Graz. And okay, the people in Vienna are very fond of this method, and we tried for several times. I'm not very excited about that. I wanted to show you why, and this is a film. So you see the baby is breathing spontaneously with a T-piece. You see he's having retractions. A very good example of this ineffective thorax expansion of the baby. Then we're using the laryngoscope. You cannot use any kind of sedation in a baby with 24 or 25 weeks because the baby is not going to breathe. So you have to put it, which is ethically in my hospital a problem. Then you put the gastric tube. We put it through the nose because it's very easy to, the tube goes out again from the trachea or get too deep. And in the nose you can fix it probably better. So you put the tube and then you connect the surfactant. Okay, we're fixating the tube and putting the CPAP as fast as possible. But you see the baby is now making an apnea. So in my eyes, this is not a method without any ventilation. There is some ventilation, probably not invasively. But we have to ventilate some babies, at least with a mask. And then you have to apply the surfactant very slowly, maybe in a time of 5 or 10 minutes, which is also a paradoxon because we have learned that the fast application of surfactant improves the distribution. And in this case, you're giving the surfactant very slowly. They presented results which are not bad, comparable to the Ensure therapy. But in my eyes, is this method not much better than Ensure? Especially because it's very difficult to put the gastric tube. It's probably more difficult than to intubate. And if you give non-invasive ventilation, at least the theoretical advantage of this method is gone. If you say this is a method without any kind of ventilation, you should ventilate the baby, even not invasively. So now we are applying the surfactant, and the baby is breathing spontaneously. We changed 2003, I think is, I don't know if you can see, I think 2003 is this year here. And we started making Ensure. The time of ventilation before that was already short, maybe 1 to 2 days. But as you saw, many babies in Ensure, they are ventilated for seconds, maybe 15 seconds, 20 seconds, not more than 1 minute. And we could found for us, these are data from the network Oxford Vermont. You probably are part of that. And this, the black column is our center. And the gray column is the main of all centers included. And we could reduce, I cannot assure you that this is the only measure that contributed to that, but this is one of the main changes we made in 2003. And we could have now probably half of the incidence of EPD and much lower than the rest of the hospitals. And we believe that this is related to the application of surfactant immediately after birth, the avoidance of mechanical ventilation, and of course CPAP. So the first therapy. Every preterm infant is put immediately on CPAP after birth. And then you can decide if the baby needs it or not. So these are the take-home message for you. Respiratory distress syndrome causes lung damage and inflammation, not only because of mechanical ventilation, but also by spontaneous respiration with a low lung volume. Inflammation inactivates surfactant, causing more damage, air leaks, pneumothorax. Surfactant should be given as soon as possible. And maybe the respiratory pattern could be an indication enough to give the surfactant administration. So these very inflexible rules of giving surfactant only if the baby has an oxygen dependency of 40 or 50 or 60% are probably wrong. What we are doing in a hospital is we are evaluating the respiratory pattern. If the baby has lots of retraction, this is a very, very reliable sign of a bad compliance. Even if the baby is needing only 25%, we give surfactant. We wait approximately for 15 or 20 minutes. We have to put a line, as you observed. We put a line. We need maybe 10, 15 minutes. And if the baby after 20 minutes is having lots of retractions, we don't pay attention to the oxygen dependency. We give surfactant. Okay? This is not evidence-based. This is what the impression we have from the studies and from the clinical practice. And Ensure seems to reduce the incidence of BPD and air leak incidence because it contains the three pillars of the therapy. Early CPAP immediately after birth, early surfactant administration, and avoids mechanical ventilation. This is very interesting. I was in a hospital invited last year in Latin America, and they said, yeah, we use also early CPAP. And then I ask, how does it function? How is it? Yeah, when the baby comes to the NICU, got immediately a CPAP. And the NICU is on the second floor, and the delivery room is in the first floor. And I said, and how long it takes until the baby comes to the NICU? Not too much, maybe 2 hours. But they call it early CPAP, you know? So you have to be very precise what you're talking about. And early CPAP means immediately after birth. Should mean that for you.
What were you doing the first 2 hours?
Everything what you can imagine. Drying the baby, giving some CPAP on not in all places, sometimes CPAP. Then with they call for the transport incubator to come. They put the baby there, then go to the elevator. The elevator is sometimes broken, so you have to go probably through the stairs. So bureaucratic problems, actually, with delay the treatment of the patient. The patient has to be admitted, gets an X-ray picture. After the X-ray picture, they can put on CPAP. So it's very complicated. But I think the main point is that the people didn't realize what means early and how important it is. It's sometimes not a problem of the logistics, it's a problem of what we are thinking about and how we observe things, how we consider things. If you consider, which is very important, the X-ray picture for them is very important. They want to see the respiratory distress syndrome. You know, probably the baby has no option. This is the only one diagnosis which is really reliable for the small preterm infant, no corticoids. You're probably 99% sure that this is a respiratory distress syndrome. But they have learned that you need a picture to make the diagnosis. So the picture has a very, very important value in their scale. And the early CPAP, not so much. So we have, the first thing is to change the way how we think before we change the logistic and the other things in the hospital.
But I think they must help the child in some way, because otherwise they will stay between 2 hours.
Yes, I try to make my contribution, but my modest contribution. There are many, many things depending on the country you visit. I realized in another country, in another hospital, a few months ago, that always when they give CPAP, they use 100% oxygen. And I thought I was hearing wrong. They said, no, we don't have any blender. So if you put the babies on CPAP, they get 100%. I don't know what's worse, I must say. So I was really shocked. And to solve this problem, I was involved in looking for the solution. It was very complicated. Very complicated. Because a blender is very expensive. On the other hand, they have ventilators, but they don't have blenders. So it's sometimes really difficult. It depends on how they see things. They thought, oxygen is not so bad. you will see in one of the lectures of Mario Rojas that it is. Okay, thank you very much. Do you have questions? Yes.
Thanks a lot for your speech. I have two questions, please. It seems that you have to use high pressure when you give the surfactant and you use the CPAP very early. You didn't mention anything about the chest X-ray. I mean, if there's lung hyperinflation, you don't take it into consideration about the blood supply. If you are using, for example, 6 pressure.
You're talking about CPAP?
Yes, of course.
Uh-huh. And the question is?
If you are making chest X-ray and you are finding that you can see up to 9 reps, for example, and the diaphragm is in this level. You don't take into consideration this thing for the blood supply?
We don't take any X-ray picture before giving surfactant. It takes too much time. We have to call.
If you make the X-ray and you find there is a lung hyperinflation, you don't reduce the pressure or you keep it high?
If you see hyperinflation, something is probably wrong. But we usually do not see that.
When you are using high pressure, you don't have always a hyperinflation. When you are using the CPAP?
Usually not. Usually not. Because if you want to cause hyperinflation and the baby is sick, you need a huge pressure, first of all. Second, you can produce very easily hyperinflation if the baby is healthy. In that case, the baby wouldn't need probably a CPAP or not so high level of pressure. But you know, probably the oxygen dependency, as I told you, this is a physiological principle. If you have alveoli which are collapsed, are closed, or not being ventilated because there is more, you will have an oxygenation problem because the whole surface for diffusion will be reduced. Okay? If a baby needs only 21% of oxygen, you can assume that probably all of the alveoli are open, the majority of them. Okay? So it's very difficult if you have a baby with 40% oxygen dependency and you have pressure of 5 or 6, maybe 7, that you see really a hyperinflation. You have to remember that the respiratory syndrome is an inhomogeneous disease. Yeah. Not all alveoli have the same compliance. This is one problem.
Yes, it's a problem.
This is one problem. Yeah. But I wouldn't recommend you to take a picture before you give the surfactant because it takes at least 30 minutes.
Say after that, I mean after 2 hours, after 1 hour, and you see there's hyperinflation. Is it a problem or it's not? That's my question.
First of all, it's very difficult to assure that this is a hyperinflation. There's a very poor correlation between the level of diaphragm and the real lung volume. There are studies about that.
In high frequency, we use also the same criteria.
We have nothing else. That's the problem. We have nothing else.
So
but,
we have to use it.
But it's not really reliable. Of course, if the diaphragm is here in the umbilicals, it's probably hyperinflated.
We're accustomed to seeing that when we use high-frequency ventilation. And we know that because our babies become hypotensive. And so the only way to resolve that is to give volume because you want better venous return because they're overinflated and your intrathoracic pressure is very high and the baby's hypotensive. And so you give volume and the baby looks good, but the real solution for that problem on high-frequency ventilation is to decrease your mean airway pressure. But there you see babies that are getting peeps of 17 and 18. Here we're talking of peaks of 5, 6, 7. That does not tend to produce what you usually see with high-frequency ventilation.
That's
so
correct.
Somebody asked me, with respiratory therapists, well, what is the right peak to start or CPAP to start on a baby? And they would tell us, well, there's not a number. We have to examine the baby. And if we don't hear any breath sounds when we put them on people 5, it might be that this baby who has more lung disease might need 6. Or might need 7. So it all depends on the patient. And so it's tailored to each individual patient. But we don't put every single baby on 5 or 6. It depends on each patient. And I think that, we've even used, this Colin Molly study used people, a CPAP of 8, which we don't tend to use. And I don't think that they had that same amount, that same problem. Or I don't know if it did affect them. That's something that they have to look at. But usually in that range of 5 to 6 to 7, you shouldn't see that problem.
I think this discussion on the pressure, which is correct on CPAP, is a discussion that in the presence of surfactant has no value. If you don't have surfactant, we can discuss. If you can increase to 8, maybe more, I don't know. But if you have surfactant and you need more than 6 or 7, this baby needs surfactant.
Yeah, but your main point is to keep him in the CPAP, not to go to take him from medical ventilation, because if everything fails, you have to go to traditional way.
That's correct.
So your point is you want to keep your patient on the CPAP. So you have to do all your best.
Yes.
This is one my question. So you are not afraid about the hyperinflation. That was my question. You will not take it into consideration.
No, we are not afraid of that.
And second question, is there a minimal duration that you should keep your patient on CPAP?
This is a very difficult question. This is a very difficult
Because
question.
we are always having this discussion in my head.
Yeah. You know, when you compare what many hospitals in the States are doing and what we are doing, they will probably think we're crazy. Because we have many, many babies for several weeks on CPAP. They have long pauses of maybe 6 hours, and then they get CPAP. And this decision is a decision of the nurses. We have very little influence. We all agree these babies are not very sick.
Well,
Not very sick. But they have a tachypnea. Let me complete. They have a tachypnea, and many nurses say, okay, the baby is breathing more than 80. I put the baby again in CPAP.
Yes.
They get approximately 5 centimeters of pressure, 4 or 5. Very seldom more than 6. Okay. And I don't know if this is necessary. I don't know if this is good. But what I can tell you is, and this is very interesting, we know that the positive pressure in the lung stimulates lung growth. This is one of the main reasons to put a balloon in the trachea in babies with congenital diaphragmatic hernia. Because the pressure which is created by the fluid which is being produced continuously in the lungs stimulates somehow lung growth. This is just speculation. But there are people saying that probably if you apply in a baby with the risk of BPD, and you know the BPD is a stop in the development of the lung. If a long-term CPAP therapy for several weeks have an effect, we don't know. But this is, I think, a very interesting question.
Okay.
It doesn't answer you.
No, you answer me, but I will just complete another question. If you are giving the surfactant and you are using the CPAP immediately, we might use it in Athens within 10 minutes or 15 minutes. This is how it wants to take for us. Next day I told my chief the baby is doing fine, and I think that he doesn't need the CPAP anymore. He's around 25 weeks, 24 weeks. And you always say, no, you should keep him for other 2 days, because you make sure that you will not be having lung collapse after that. Is that true?
I think you have to decide individually. If the baby is breathing completely normally, has no retractions, no oxygen dependency, you can try to put it out.
Okay, I always say you should keep him at least 24 hours when there is a CPAP, so you will not be having lung collapse.
You have to ask him where's the evidence for that.
He said, many guys, they do it.
I would decide it individually.
Not to remove it immediately.
I think
He's been in the States. He was coming from the States.
Yeah, what decides, helps you decide that is if your baby was on 60% oxygen, you gave him surfactant, and you have him on CPAP, and 24 hours the baby's on room air and doesn't have increased work of breathing, why do you want to keep him on a CPAP? And so it's your FiO2 that should tell you. But if I have a baby still 24 hours on 28, 30%, I might not want to get the
His
baby
answer
off the
always
CPAP.
is to avoid lung collapse.
Yes.
Not to have a tendency. This is his answer always.
Yes.
You should keep him at least for 24 hours.
But if you've done well with your surfactant and your baby's now on room air and doesn't have increased work of breathing, it's because your surfactant therapy has functioned. Your focus is the baby has surfactant deficient disease, and you are replacing that. And once the baby has sufficient surfactant, has no more surfactant deficiency disease. So the time that the baby requires support is when the baby's you're able to bring them down to room air, and the baby doesn't have increased work of breathing. I wouldn't leave the CPAP. There are babies that might need it 3 days. Others might need it 24 hours. We don't keep there are babies that we can't get them off the CPAP for 2 weeks. There are special cases of babies that it's not just only the surfactant problem, but our trend is if we get them down to room air and they don't have work of breathing, stop it. And some babies are being put on nasal cannula, and a recent study just showed a randomized control trial that putting babies from CPAP to nasocannula doesn't make any difference. You can take them off the CPAP directly if they don't have increased local breathing and they're doing it.
Thank you.
In regards to the avoid mechanical ventilation study, the one with the nasogastric tube, I think that there are sort of different methods, because some groups, they keep the CPAP via prongs or mask, so they don't put it away like you did with the paraben. So I think by keeping the CPAP with the prongs and then putting the nasogastric tube by an oral way, I think that's kind of a different way, because you keep the pressure and therefore sort of you still recruit the lung or create an FRC, and therefore sort of you don't have the problem to re-establish lung volume during the application of surfactant, or why you put the nasogastric tube in. And I think that might make a big difference.
This is a good question, because I think that if you open the mouth very widely, the pressure is lost. Because you have a tube to the nose and you have a big opening in the mouth. I don't believe that you can keep the pressure that way. If you keep the mouth closed, I agree with you, but the problem is how to put the gastric tube, the mouth is closed.
Yeah,
This is the question, yeah?
Yeah, as well, sort of how quick you sort of can after the procedure, and how quickly sort of, I think it depends as well sort of on the experience, and but of course that you might lost the pressure, but yeah, from what I know, I heard that sort of the babies are more stable when they sort of keep the prongs.
Maybe, I don't know.
And one other question, sort of how high was the reintubation rate in the two studies, in the COIN study and the support study, and the babies just sort of treated with CPAP?
Now you have.
So,
Do you have the data from your study?
From our study, as we said, the babies that got surfactant, 26% of them did not require any reintubation. 74% were successful. But of those, of those babies, the ones that we had were late failures, and what we call late failures, because we had criteria for early failure. You know, if you had a pH less than 7.2 or PCO2 greater than 65, we would stop and intubate and put in mechanical ventilation and give surfactant. But the babies that we had on later failure were babies that had sepsis and were on CPAP. And then that was 2 or 3 weeks after that they required intubation or mechanical ventilation. But the majority of our babies did not have failures if it wasn't for something like infection and apnea. Our study was different from the other studies because we also had a less rate of apnea because we gave all our babies prophylactic methylxanthines, because we didn't want to have babies to fail because they were having recurrent apneas. The other studies did not use that therapy. So it's part of how we treat babies now from the beginning in the delivery room. After they get their surfactant, they're placed on CPAP, they get immediately their treatment for apnea. So our failure rate was much lower. But if you look at all the studies, you put them together, failure rates vary significantly between each study. That's something that we'll show you.
Yeah, because I remember, I think in the COIN trials, the group treated just sort of CPAP, the reintubation rate was sort of, or not the reintubation, the intubation rate after, I think, 3 or 4 days was quite
significant.
In our study, if you see need for second dose surfactant meant that you had to be intubated.
Yeah.
So it was 12% in the surfactant group and 24% in the other group. So those are the differences, because both were CPAP. But when you got your second dose, that's because you were on a ventilator and got intubated. So it was 12% versus 20. It was a drop in 50%.
There's a study showing that probably the parameter which correlates best with the failure of Ensure is the gestational age.
Yeah.
So it depends on the age of babies you take. If you eliminate 24, 25, 26, the reintubation rate will be very low. If you take these small babies, it's very high. And that's also our experience. In very, very small preterm infants, many of them had to be ventilated, not because the lung condition is very bad, because they make lots of apnea. This is the main problem.
Are there assessments of the effect of surfactant and CPAP on cerebral circulation, on blood, on how the way blood flows into the brain?
Yes. I'll show some of that data in what I'm going to present, but they compare, and this is in babies, no ventilation, CPAP, and mechanical ventilation. And they do different techniques to measure cerebral blood flow. And they show that when you are placed on mechanical ventilation, you have a significant drop in cerebral blood flow compared to when you do CPAP, which is very similar to when you're breathing spontaneously. So it does affect that, and that's a question that's not been answered because all our trials have been short-term. You see, need for mechanical ventilation is a short-term outcome. But we need to do the long-term data, and that's missing. Because somebody can argue, well, this is good, so good, but high CO2s might produce, poor developmental outcomes. Show that, and we don't have any data to be able to support that. But on the contrary, you might find that being on mechanical ventilation, because they're physiologic, we know that decreases blood flow. Those babies might do worse from a developmental perspective. But nobody has ever compared CPAP with surfactant in the first hour versus mechanical ventilation and surfactant in the first hour, and then followed those babies for their short-term outcomes, but then looked at neurodevelopmental outcomes and see what the differences were. We don't have that study. It's not been done. And so nobody can answer that question, but that's a very important question to answer.
Just one comment I would like to make that, and then I answer your question. I think it's very important when you are talking about cardiovascular function and respiratory support to analyze exactly what you're doing. Because we have the tendency to say high-frequency ventilation reduces the cardiac output. CO and CPAP reduces the cardiac output. But that's not always true. And sometimes it's even the opposite. There's a golden rule, for example, in the pediatric intensive care unit. If you have a baby or a patient with cardiovascular compromise, like heart failure, you shouldn't never accept that the patient develops a respiratory failure, insufficiency, with retractions. Because if you allow the baby, in this case a baby, to breathe with retractions, you already saw the baby causes a very negative pressure in the thorax. And a negative pressure, what makes with the heart is it tears the heart from both sides. And this is an opposite force to the contraction force. If you read the book of physiology, you will read that the respiratory failure, a negative pressure, increases the afterload. It doesn't have nothing to do with the resistance of the vessels in the periphery. It has to do with a force which impedes the contraction of the heart. Because this negative pressure is pulling the heart apart. You understand? In this case, if you put positive pressure, and this negative pressure of the spontaneous respiration of the baby gets less, the cardiovascular condition will improve. And on the other side, if you want to make a compromise of the cardiovascular function by applying pressure to the lungs, you have to compress the mediastinum. And the more sicker the lungs are, the more difficult this is. For a healthy person, it's very easy to produce a compromise of cardiovascular system by applying pressure. But in a lung which is very stiff, it's very difficult to distend the lung so much that you compress the mediastinum, compromise the venous return, which is actually the first thing which is being affected. Okay.
What dosage do you use for fentanyl and naloxone?
We usually give 0.05 milligrams of midazolam or lorazepam, and then we use not more than 2 micrograms per kilo fentanyl. 0.1. It was a very interesting curve, or learning curve, let's say that way. When we started doing that, we used fentanyl alone. And you need huge dosages until the baby is not really moving. But if you use a benzodiazepine, first you can use much less fentanyl, and it has the advantage that when you give the naloxone, the baby is still a little bit sedated. it doesn't start crying. Or
Do you often see a thorax rigidity with the antenatal? Or
not in this dosage. Not in this dosage. In the old days, when we were using 10, 15, we have seen several patients with what we assume it was a thorax rigidity. Difficult to ventilate. Exactly. But not in this dosage. Yeah. 0.05.
You mentioned in Australia they were using CPAP for the full term. For what?
For the what?
For full-term babies, they were using the little CPAP.
Yes.
For what?
Babies, for example, with transient tachypnea. This is a typical example.
It's ridiculous. It's for full-term babies.
Well,
What do you think? What's your opinion?
my opinion is that they improve because this disease is characterized mainly by a higher content of water in the lung. So the compliance is effective. And that's the reason why, what's the reason?
You don't affect the communications, you use it for CPAP for full-term babies.
No.
It's not more severe.
No.
More common.
We very seldom see complications in the term baby with CPAP. And if you pay attention to those babies developing a pneumothorax, all babies, it's interesting. A pneumothorax is a typical complication of CPAP, not for ventilation nowadays. And those babies developing a pneumothorax, at least in my hospital, are babies with severe respiratory distress syndrome, where we were thinking, should we give, okay, well, let's wait. And then in the middle of the night, pneumothorax. Not the babies with mild respiratory problems, not the babies with transient tachypnea. Babies with respiratory distress syndrome and the borderline indication for surfactant. That's the reason why we got very liberal in administering surfactant.
We use it in late preterm babies. In and out.
Exactly.
You're 34 to 36, and those babies with respiratory distress, why leave them with respiratory distress for 24 hours when you can help those babies with in and out surfactant? And so our nurses intubate the babies, give us surfactant, and pull them out and put them on CPAP, and they don't need the majority. There are some that will need mechanical ventilation, but the majority of them do well unless they develop pulmonary hypertension. Late preterm.
But there are very few term infants with CPAP, that's correct. Very few.
Last discussion, but maybe it's time to wait.
Okay.
So we have a pause for 20 minutes. Please follow.